Good morning, everyone. My name is Suhail Irshad, and my study this year was comparing the surgical efficacy of hip spacers of various head prosthesis diameters on total hip arthroplasty based on patient biomechanical analysis. Oh, oh, oh. Okay. So in our daily lives, the hip is one of the most important and largest joints in our body, and it's very essential in providing balance, stability, and allowing for mobility. And it aids in our daily activities like standing, walking, and running. And while our hip joint is very strong, it's common for it to wear down, especially as we get older, and that can result in it getting damaged or fractured. And so, in that case, when this occurs, a surgery called total hip arthroplasty or total hip replacement is necessary, where, as the figure 1 shows, the animation, the surrounding cartilage of the damaged hip joint is removed and replaced with a hip implant which serves as a prosthetic joint for the hip joint. And so these surgeries are very common in the United States, with over 450,000. And while the surgery is very effective, infection rate at the surgical site is very high, and it can be devastating, with mortality rates as high as 21%. And so, two-stage revision surgery is a popular alternative where the initial infected implant is being replaced with a temporary implant called the hip spacer, which replicates the original prosthesis with its geometries and functionalities, but it's also providing antibiotics to the infected site. And so the components of this hip spacer are, like any other hip implant, the stem, the head, which is very important in the study, and the acetabular component. And so currently, this is a gold standard method with infection control rate at 90%. However, the rate of this hip spacer dislocating is also very high, with it overall complication rates being as high as 58%. And so the reason it might seem that it's due to the functionality of the hip spacer, but the literature shows that it's actually because there's a lack of guidance for surgeons in regards to a femoral head selection system. And so the head of the spacer can come in various diameters. And so the orthopedic surgeon has a variety of options to choose from. And as the figure 3 shows, it can range from 22 millimeters to 36 millimeters to even 38 millimeters. So there's a variety of options, and this prosthetic head is very crucial since it's providing support to the body and it's also allowing for mobility. And so, while it is agreed in the orthopedics research community that the larger the head diameter, the lesser the risk of dislocation, this does not come without drawbacks. Specifically, larger heads can lead to more friction and more wear, which can cause the implant to fail as well. And so, overall, there's a little consensus on which prosthetic head diameter is optimal for patients. And current research is kind of neglecting this aspect, and they're primarily analyzing the stem size of the hip spacer. And while this has been reliable in terms of the measurement of the hip spacer, in terms of the stem, this is not without drawbacks. Specifically, there are still high spacer fracture rates, 25% of which are solely occurring due to a small head diameter being implanted into patients. These studies also are lacking the consideration of biomechanical factors, which are important in analyzing how likely the implant is to fail. Because the forces in biomechanical analysis, the forces are being analyzed and seeing how that can impact the functionality of both the implant and the bone. And so this study was looking at the surgical efficacy of different head diameters through biomechanical analysis. So the independent variable was looking at the different hip spacer diameters, and the dependent variable was looking at specific biomechanical measurements, like stress values, which tells how much force there's being inputted on an implant, as well as displacement, which is looking at the distribution of the force. And so the overall hypothesis was that the 32 millimeter head spacer would have the lowest maximum stress and considerably low displacement of that stress. And so this would indicate a greater surgical efficacy because a lower force being implemented on the implant would suggest lesser risk of the implant failing. And so the procedure entailed medical image processing, CAD modeling, and biomechanical analysis. So in the medical image processing stage, a sawbone, which is a replication of a femur, replicating both the geometry as well as the material properties, was used as a way to control confounding variables that could arise with patient femur scans because there's many variability. And so this sawbone was segmented, the CT scan of it was segmented into a femur model, and this was in a image processing software called ScanIP. And so in a typical surgery, the surgeon would incise the femoral head so that the implant could be placed into it. And so this was replicated in this CAD modeling software. And so in SolidWorks, which is another CAD modeling software, the hip spacer was constructed with aid of a surgical guide. And this hip spacer, as shown in figure 7, has different diameters. So in each trial, the diameter measurement was changed to test the independent variable. And so in figure 8, it demonstrates the implant being inserted into the femur. And so this required aid from my mentor, also with a surgical technique guide. And so this model was then converted into something called a mesh, which is a compatible form for biomechanical analysis. So this required implementing the correct bone and implant material properties as well as coefficient of friction values. And so the biomechanical analysis entailed taking data from an open database called OrthoLoad, where it was simulating a patient walking. And so in figure 10, it shows the forces in the X, Y, and Z direction. And so in this software called Abacus, this load data was imported and implemented. And figure 9 is important because it's depicting the vector at which the load had to be implemented to simulate the walking experience. And cyclical loading was implemented, by which it means that this simulation was being repeated in 5 million cycles to encapsulate how a person would be walking and showing the way that the stress would be distributed over time. And so the greater magnitude of stress as well as a greater displacement of stress would indicate a greater likelihood of implant failure and overall would suggest less surgical efficacy. And so the overall results in this slide shows the maximum stress. And so the commonality between all these images is that the maximum stress is occurring on the neck of the implant. And this makes sense because the majority of the load amount is going on the upper portion of the implant towards the head and the neck. And so that makes sense as to why there is the majority occurring here. But the difference in these pictures is the amount based on the head diameter, and this will be explained later in the presentation. In terms of the maximum displacement, the displacement was mostly occurring at the femoral head, as shown by the red in the heat map. And so again, that makes sense because the majority of the force is being placed at the top of the femur since it's replicating the ball and socket joint mechanism. And so the overall conclusions were showing that the hypothesis was supported since the 32 millimeter spacer was demonstrating the lowest maximum stress as indicated by figure 20 in the table. So yellow showing the lowest amounts, red showing the highest amounts, and a considerably low maximum displacement since the 32 millimeter had a displacement value lower than the average as indicated in green. Now, the 38 millimeter had a very high displacement value as well as the highest maximum stress value. So the data trends are suggesting that the bigger the diameter, the lesser stress that is being exerted. However, until a certain size, where when the diameter gets too big, then the maximum stress will be exceeding average values and creating a greater risk of implant failure. So overall, the 36 and 32 millimeter spacers were showing to be the most surgically optimal because they were indicating lesser stress values with also below average maximum displacement values. And
Suhail,
so,
you have 2 minutes remaining.
all right. So these were indicating that the more extreme values, whether it was 22 millimeters or 38 millimeters, were suggesting higher values of stress and displacement as opposed to values like 32 millimeters and 36, which indicate a greater choice of efficacy. And so the figure 21 is just showing a more graphical representation of the table. And so the overall implications are that this study can provide more guidance to surgeons when selecting the spacer for surgery and can help prosthesis manufacturers to choose the more optimal head diameters. And so overall, this can help enhance the quality of care for patients and even reduce the risk of further complications in THA, which is really important. And so in the steps forwards, the study can be expanded by including patient data as well as quality of life surveys as a means to further expand and create more nuance to this study and add a functional aspect. So thank you very much for listening to my presentation.
Very nice work.